Carolina A. Mello, Daniela M. Silva, and Aparecido D. De Cruz. Challenges in clinical and laboratory diagnosis of androgen insensitivity syndrome, a case report. Carolina A. Mello, Daniela M. Silva, and Aparecido D. De Cruz. AIS overview. AIS is an X-linked disorder caused by mutations in the androgen receptor gene. May cause a wide range of phenotypes from male infertility to completely normal female external genitalia. Complete AIS is relatively rare. Subject with normal male karyotype, 46, Xi, presence with female external genitalia, absence/thinning of pubic hair, and absence of the uterus. Most individuals not diagnosed during childhood are diagnosed after puberty due to primary amenorrhea. http://www.youtube.com/watch v = atixic. Background: androgens. Androgens are a group of sex steroid hormones, primarily produced by a male's testes. Responsible for male sex differentiation during embryogenesis. The sex-determining region on the Y chromosome, SRY, directs androgens in male differentiation. This differentiation occurs between the 9th and 13th weeks of pregnancy. Both testosterone and DHT are required for this differentiation to occur, and these androgens, in turn, require the presence of functional androgen receptors to exert their necessary effects. Androgens are also responsible for male secondary sex characteristics by triggering puberty. Background: R gene. The R gene codes for a protein that is a steroid hormone-activated transcription factor and is found on the X chromosome. Protein coding region consists of 8 exons. R equals androgen receptor. In the absence of a ligand, the R resides in the cytoplasm. Upon binding, the receptor dimerizes and translocates to the nucleus, where it exerts its effects on transcription. Consists of 4 main regions. N-terminal domain, DNA binding domain, hinge region, involved in DNA binding and R dimerization, ligand binding domain. Figure 1. Background: causes of AIS. Loss of function mutations in the R gene cause AIS by leading to androgen unresponsiveness, which affects proper male sexual development. Results from a reduced capacity of the R to transactivate androgen responsive genes and target cells. Background: AIS. The phenotypes vary according to the R defect. 3 classified forms. Complete AIS- appear as normal females until puberty hits and menstruation does not occur. Partial AIS- heterogeneous condition with a variety of phenotypes depending on different degrees of undervirilization. Mild AIS- underdeveloped males with ranging fertility. All forms are inherited as X-linked recessive disorders. Affected patients have the normal male karyotype, 46, Xi, with female external genitalia, blind vaginas, an absent uterus, normal breast development, and abdominal or inguinal testes. Usually come to attention during the neonatal period due to inguinal hernia and/or ambiguous genitalia, or at puberty due to primary amenorrhea. Purpose of investigation: to provide a genetic diagnosis of a teenage girl with normal male karyotype, 46, Xi, using fluorescence in situ hybridization, FISH, and PCR in order to determine the nature and the extent of the mutation that affected the R gene. Case presentation: 15-year-old Caucasian girl referred for genetic testing due to primary amenorrhea. Medical history of removal of an abdominal mass as a newborn. Mass referred to as umbilical hernia. G-band karyotype revealed diploid set of chromosomes, including 22 pairs of homologous autosomes and 1 pair of sex chromosomes, compatible with a 46, Xi. Geneticists at Brazil lab concluded that the mass withdrawal was in fact testes, and the patient had a condition known as cryptorchidism. It is reproductive change characterized by a failure of the movement of one or both testes from the abdominal cavity to the scrotum. Case presentation, continued. PCR verified mutations of the exons 1, 4, 6, 7, and 8 on the R gene. Primers were used for selected exons of R. FISH was used to detect the R gene. Culture of T lymphocytes in RPMI 1640 medium, supplemented with 20% CAF serum and 2% phytohemagglutinin. Slides of good quality, in terms of metaphase, were selected by phase contrast microscope and were subjected to FISH using the LSI androgen receptor spectrum orange, XQ12, probe. Case presentation, continued. In situ hybridization with the LSIR probe indicated presence of the gene in all analyzed cells. Genomic DNA extracted from peripheral blood leukocytes assessed by PCR revealed coding sequence abnormalities for the R gene, which lacked exons 1 to 7 indicating a large deletion spanning the proximal region of the gene. Figure 2. Figure 3. Figure 4. Conclusions. FISH alone was not able to properly diagnose the patient, despite the proximal deletion within the R observed on PCR. Explanation: the probe was 380 kilobits, which was bigger than the R gene, 90 kilobits indicating that the deletion of some exons within the gene was not large enough to prevent probe hybridization. The PCR assay confirmed the diagnosis for the patient having a chromosomally normal male karyotype. Conclusions, continued. Mutations affecting the R gene may cause either complete or partial AIS. The patient reported is consistent with case, misdiagnosed at birth, and consequently raised as female. Discussion. It is critical that healthcare providers understand the importance of properly diagnosing a newborn with ambiguous genitalia. Evaluations of clinical and genetic findings is crucial to determine proper gender assignment and detection of life-threatening condition. A child with pseudohermaphrodite phenotype should undergo adequate endocrine and genetic testing for a definitive diagnosis before gender is assigned or surgery is performed. Inadequate investigation may result in inappropriate gender assignment in infancy with possible inferences on outcome. A patient with abnormal genital development represents a difficult diagnostic and therapeutic challenge. A patient with abnormal genital development represents a difficult diagnostic and therapeutic challenge.